Hey guys, Miss Hill here, and this is the continuation of our individual module 5.2, PowerPoint 2, lecture number 4. We're going to finish out talking about maternal high-risk patients and complications that may be experienced during labor and birth. So the first thing that we are going to talk about is dystocia. And dystocia just basically means a difficult birth. What happens in dystocia is that there is an issue with one or more of the 5 P's. So we have to remember first, what are the 5 P's? Passage, passenger, passenger relationship, power, or the psyche. So let's start with passage. There are several things that can affect our passage when it comes to dystocia. So, cephalopelvic disproportion, where the baby's head and the mom's pelvis are not favorable to allow passage of the fetus through that. A full bladder. A full bladder can cause dystocia because as the bladder becomes filled up with urine, it does not allow room for the fetus to pass down into the pelvic inlet or through the vaginal canal. You know, those organs are sort of in the same area. So if we've got a nice full bladder, it leaves a lot less room for the baby to descend. And then an unfavorable cervix. And what this means is that we have a cervix that is not really ripe enough to either A, lend itself to dilation or effacement. The passenger, there are obviously several different things that can affect the passenger when it relates to dystocia. The size of the baby, the way the baby's presenting. So is the baby breech? Is it a shoulder presentation? Is there a transverse lie? What attitude is the baby in? And how many number of babies are in utero? More than one fetus can cause a mom to experience dystocia during labor and birth. Also, remember here that positioning of the baby as well. So if the baby is presenting posterior, that causes more dystocia than, for example, a mom who has a fetus that's presenting anterior. The passage-passenger relationship. Arrest of descent basically means exactly what it says. It is the stopping of the fetus from descending any farther into the pelvis or the vaginal canal than it already is. So if we cannot get the fetus to descend properly, then obviously we're not going to have a good outcome for a vaginal delivery. And then malposition. So again, back to that posterior positioning of a baby. And then power. What is included in power? Well, we know power includes both contractions and pushing effort from the mom. So anything that can affect those two things can cause dystocia. Hypotonic or hypertonic contractions. So contractions that are not effective enough to dilate and efface the cervix are hypotonic. They're not strong enough. And then hypertonic contractions are too strong and might cause other problems. For example, if they are strong enough that they increase the pressure in the uterus to a point that's unacceptable, we could end up with a uterine rupture. Fatigue. If mom becomes fatigued, then her pushing effort is not going to be adequate to lend itself to delivery, and we end up with dystocia. And then effects of sedation. Remember, we have to time our pain medication effectively whenever we are attempting to promote comfort in our laboring moms. And one way we do this as labor nurses is by timing those medications appropriately. If we give medications or epidurals too soon during the labor process, then it can actually cause dystocia during that labor, because it will cause contractions possibly to become hypotonic, and that makes the laboring process a lot longer for moms. And then we always have to remember psychological effects, or anything really that we talk about in this class, but it is one of the 5 Ps. And so specifically, think of prima gravida mothers. These guys are brand new at going through this whole process. Their bodies aren't particularly used to this yet. It's the first time they've gone through it. Typically, prima gravidas tend to have a lot longer labor process than multigravidas, and they're more nervous, they're more anxious, they don't know what to expect, so their psychological state can lead to dystocia as well. Obviously, these examples are not all inclusive, but I've given you some listed here that you probably would see most often. So what are risk factors for dystocia? Short stature. Moms who are short, moms who are overweight, your older moms, ladies that have uterine abnormalities, or inappropriate timing of anesthesia and analgesics. Those are all risk factors for contributing to dystocia. Moms with a short stature, if you think about the way their bone structure is, they just don't have as much room as an averagely built person, I guess. Overweight individuals tend to fatigue out very easily. Advanced maternal age. These guys have bodies that are just older than your average childbearing mom, and their uterus tends to be a little more tired, and they get fatigued a little more easily. Ladies with uterine abnormalities, if your uterus is an abnormal shape, then that affects the power of how it can contract, potentially. And then we've already talked about the inappropriate timing of pain meds. Signs and symptoms that you'll find as a nurse taking care of someone with dystocia is that they will have a lack of progress. And the way we assess this is through cervical dilation, effacement, and descent. So your assessment tool to be able to determine that someone is having lack of progress is a sterile vaginal exam. Checking for that dilation, checking for that effacement, and checking for the station of that baby. And then ineffective pushing, or moms that have no urge to bear down. They don't feel that pressure in their bottom to be able to know whether they're moving the baby down effectively or not. How do we manage dystocia? Couple of ways that are good for us specifically are IUPCs, so the intrauterine pressure catheter, and the FSE stands for fetal scalp electrode, so that means we can trace the baby's heart rate internally. And IUPC means that we can trace the power of contractions and the pressure inside the uterus internally, and to the exact degree. And this is very important because if we have someone experiencing dystocia through a power, lost my train of thought, guys. if we have someone who's experiencing dystocia and it's related to the power portion of our 5 critical P's, then we can use that IUPC to determine how well our Pitocin is working in terms of augmenting labor. So if we start someone on a Pitocin drip and we have an intrauterine pressure catheter in place, it allows us to be able to more closely manage our pit drip in order to make those contractions effective and powerful enough so that we can overcome that dystocia. Think of it as a patient who's on a critical blood pressure drip in the intensive care unit. If you have someone that you have on a dopamine drip and you are having to monitor their blood pressure with a manual cuff in order to titrate your dopamine drip, imagine how difficult that would be. You really need that person on a monitor, and preferably with some internal monitoring devices so that you can keep track of the specific blood pressure and keep track of their specific central venous pressure at the same time. That really allows you to be able to titrate that dopamine drip a lot more effectively than if you were trying to use a manual blood pressure cuff to determine what to do. It's the very same thing whenever you think about utilizing the IUPC in terms of managing dystocia because of contractions. Also, we can assist the doctor with amniotomy. That means breaking mom's water. So if we artificially rupture her membranes or perform an amniotomy, that will help progress labor. Encouraging mom to void. We've already talked about the full bladder blocking the passageway. If we encourage voiding, we can keep that bladder decompressed and hopefully allow more room for the passenger to descend into the passageway. Also, we want to encourage position changes. If we have a baby that is positioned posterior in mom, if we encourage mom to flip from side to side, we might need to put her in the chest position. We could put her on a birthing ball. We may be able to allow her to rock in the rocking chair, depending on what she's got going on. If we encourage lots of position changes, that can also encourage the baby to change positions to a point that's more favorable to allow the baby to descend into the pelvis. Assisting with relaxation is also important. When moms are very tense and they're physically tense, their muscles are tense, they're in pain, they're stressed, that tends to lend itself to dystocia. If we can relax a mom, if we can relax her muscles, we can relax her body to a point that labor is just allowed to sort of progress without a mom's body sort of fighting against that natural process, we can hopefully prevent dystocia or correct it. And then effective coaching during the second stage. So you got to remember what the second stage is. That's where mom is pushing. Continual fetal heart rate assessment, always important. And then administering medications necessary to prevent dystocia. So that could be pain medications to assist with that relaxation, or that could be Pitocin to increase the power of some hypotonic contractions possibly. Another thing to mention here is that if we have some hypertonic contractions, it may be that we need to give mom a lactated ringer bolus to hydrate her a little bit and make her uterus less irritable. Or we may need to hit her up with some terbutaline so that we can space contractions out some. All kinds of different things we can do to manage this. All right, so let's compare the contraction types. So in relationship to contractions, hypotonic contractions are ineffective. They're not good in terms of progressing to our end goal, which is a vaginal delivery of healthy mom, healthy baby. Usually hypotonic contractions occur during the active phase of labor. So mom hits the active phase, and then her contractions do not become strong enough to progress her over into transition. They're painless, usually, and we can augment these with some Pitocin. We can make them stronger and monitor progress through sterile vaginal exam. We could utilize an IUPC. And usually sedation at this level is of little value. So, for example, giving mom some pain medications, if her contractions are already hypotonic, are not going to help. It's just going to cause those contractions to be even less effective because it's going to relax her body. And already her uterus is not doing what it should in terms of power. Now, let's compare that with hypertonic contractions. So with hypertonic contractions, they are also ineffective. They are too strong. They will affect things in a negative way. Usually these occur during the latent phase. They are very painful for mom, and what we have to do here is to slow things down for her. So we may have to give her an LR bolus, or we may have to hit her up with some terbutaline, like I said earlier. Obviously, we monitor progress through potentially an IUPC or possibly with sterile vaginal exams. And sedation is oftentimes helpful here. So giving her some kind of pain medication at this point, even though it's in the latent phase of labor, usually will help because it will relax the uterus to the point that allows those contractions to be just powerful enough that we can move on from the latent phase into active and then on through transition and delivery. With dystocia, there are some things that possibly will cause some unfavorable outcomes if we cannot get things corrected. One of those things is a pathological retraction ring. And what happens there is, hold on, sorry guys. What happens there is a thickened area or a thickened ring sort of forms in the cervix and the uterus, and it does not allow labor to progress like it's supposed to. You do not have to know exactly what that is for your test, but I just wanted you to be aware that's something that can happen. Precipitate labor. This means a labor that happens really, really fast. So, for example, if we cannot get those hypertonic contractions decreased with intervention, then mom may experience a precipitate labor, which means from beginning to end, less than 3 hours. That's really hard on a mother's body because, you know, there is a reason why labor takes such a long time. And the body has to prepare for all of those things to happen. The soft tissues have to stretch, the pelvis has to stretch, all kinds of things that have to happen to allow a normal labor that is safe for mom and baby. A precipitate labor can be dangerous, and it can occur because of dystocia. And if things happen super duper quick, you know, it's like, I don't know, shooting a cannonball through there. It's not favorable. Uterine rupture is a possibility if we can't get those hypertonic contractions taken care of. Remember, if we have too much pressure inside the uterus, then we put moms at risk for uterine rupture. Really bad thing. We don't want that to happen. Same thing with uterine inversion. Uterine inversion means basically that the uterus just turns inside out. And this can also happen when the contractions have some hypertonic characteristics. Postpartum hemorrhage can happen whenever the contractions are hypotonic. When dystocia happens to a mom, postpartum hemorrhage is definitely one of those unfavorable outcomes, because if the uterus is not working well during labor, it's not going to work well after delivery, which means that if we can't keep the uterus clamped down, contracted, and nice and firm, then mom's going to be at a huge risk for postpartum hemorrhage. Amniotic fluid embolisms are also another unfavorable outcome that can happen in relation to dystocia. And this is just where an amniotic fluid bleb or bolus gets into mom's circulatory system and causes an embolism. Those usually typically have a really bad outcome. And then non-reassuring fetal responses. Obviously, if we have a labor process that's not going appropriately, it can potentially affect the baby's heart rate. So we can have some non-reassuring responses noted on our monitoring strip because of these. So how is a way that we can manage maternal exhaustion or poor pushing? Here is another extension of our power portion of one of those 5 critical P's. Couple of ways that we can do this is through forceps delivery or a vacuum extraction. Now, I'm going to see if I can use my little pen here. Oh no, it's not going to let me. Nope. Okay. Oh well. All right, so these are forceps right here. They look like little salad tongs with a hole in the middle, sort of. And those can be applied on either side of the baby's head as to assist mom with pushing. And so what happens is, with a contraction, as mom pushes, the physician will apply these forceps on either side of the baby's head and pull while mom pushes with her contraction. The vacuum extractor, or Kiwi, is another term for that. That's a brand name. That is a suction cup, and it's applied to the baby's head and used in very much the same way the forceps are. Forceps, you don't see those used a whole lot anymore because they have some pretty bad disadvantages. They can, when used improperly, they can actually crush the fetal skull. They can cause ear problems, eye problems, nose problems, anything on the baby's face. They can cause cervical tears, uterine ruptures, and so we have to be really careful when using forceps. With the vacuum extraction, a couple of disadvantages with the vacuum extraction is that it can actually leave a hematoma on the baby's head. It's just like applying a suction cup to your skin. If you leave it on there for long enough and somebody pulls on it hard enough, you're going to end up with a big fat bruise there. So if we do that to the fetal head, then obviously we can potentially cause a hematoma, and that's something that you'd have to assess for afterwards. The advantages of using either of these things is that it helps whenever mom is super exhausted and she's got a poor pushing effort from whatever. Maybe she has no feeling of pressure in her perineum, and she can't feel to push effectively. So these couple of tools come in very handy at helping with that. It's very important to monitor the fetal heart rate and to monitor mom, especially in terms of bleeding, whenever you have a physician that opts to use either of these two methods. So what are intrapartum high-risk factors? They're physical and mental conditions that increase the chances of something else to occur during the process of labor and birth. So it could be a maternal or a fetal factor, but either way, it jeopardizes the safety of the mom and the baby together. So sometimes these high-risk factors can be coexisting or happen prior to the onset of labor. Sometimes they actually will occur during the actual labor process, but these individuals have to be monitored and managed much more closely than your average healthy mom who is not at high risk. Potentially, these people have to end up with an expedited delivery to end up with a positive outcome for mom and baby. So, for example, think of your preeclamptic mom. If her pressure continues to increase and increase and increase, then we may have to expedite her delivery so that she does not end up in an eclamptic state, so that we can have a better outcome for both she and the baby. These factors can result in injury. They can result in morbidity and mortality for both mom and baby, and obviously there can be a lot of emotional distress that goes along with these high-risk factors. So here's a list of them, and I will just read them to you quickly in case you're listening and not looking at the screen. So some different maternal intrapartum high-risk factors include, and these are maternal ones, chronic medical illnesses such as cardiovascular disease, diabetes, hypertension, past surgical procedures, post-term pregnancies, intrauterine fetal demise, preterm labor, dysfunctional labor, placenta previa, abruptios, inadequate pelvic measurements or cephalopelvic disproportion, low socioeconomic status, cultural beliefs and practices, uterine rupture, no or minimal prenatal care, an unwanted pregnancy, moms with substance abuse issues, mental illness or psychological issues, partner abuse, post-traumatic stress syndrome, trauma, obesity or malnutrition, exposure to teratogenic substances, amniotic fluid embolisms, retained placenta, young and advancing age clients, unknown presenting parts of the fetus. So, for example, your breech. And then a few fetal intrapartum high-risk factors would include non-reassuring fetal status, abnormal presentations, multiple gestation, oligo and polyhydramnios, meconium-stained fluid, umbilical cord prolapse, macrosomia, which means large baby, umbilical cord anomalies. So, for example, maybe your umbilical cords that only have one artery instead of two arteries in a vein. Or umbilical cords that have gotten entangled around the fetus, or maybe have a knot or a clot on the inside, all kinds of different things. So, we're going to go through a few of the high-risk factors, and we're going to start out with post-dates and post-term. Our concern with moms who are post-date and babies that are post-term is the viability of the placenta. The placenta is only made to last for so long. It is not going to last on and on and on and on and on. And once moms get to a point where they're post-date, the placenta is basically, it's old. It quits doing its job effectively. And if that's the case, then the baby will not be allowed to have the nutrients that it needs to continue to survive in utero. And also, perfusion, that exchange of oxygen and carbon dioxide, does not happen as effectively either, and babies can end up with some hypoxic insults. So for these individuals, we may need to induce their labor if they're not going to labor on their own. But before we induce somebody's labor, we have got to make sure that they pass some eligibility requirements. Obviously, we have to make sure that their pelvis is adequate to accommodate the baby on the inside. Post-date and post-term babies tend to be larger kids because they've spent much longer time in utero. And if they're larger, then there is a risk that they will not fit through the pelvis. So we end up with a passenger relationship issue. The babies also must be cephalic. They got to be in a head down position for us to induce labor. If the baby is breech with the butt down, we would never induce labor on that person because we know that we're not going to deliver them that way. Also, we have to make sure that it's been validated that the pregnancy definitely is term. So either by an ultrasound, by gestational date. Those are usually the two main ways that we validate a term pregnancy, is ultrasound and date. And sometimes it may be necessary to do an amniocentesis. A Bishop score means how favorable is the cervix. How well is the cervix going to lend itself to a labor induction? So remember that we talked about the cervix being ripe for delivery. The Bishop score is something that we can do on sterile vaginal exam. It's just a scoring mechanism and a tool to tell us how favorable that cervix is going to be in relation to inducing labor. If the cervix is not ripe enough, then we have to start out with some different types of medications to induce labor instead of something like Pitocin. We would want to start out with something like Cytotec or Cervidil to ripen the cervix first. And then also there may be an urgent need to deliver, and that may be another reason why we have to induce labor. So what types of methods can we use to induce people? You guys already know many of these, but quickly we'll go over them. The IV drip of Pitocin in a piggyback. That is one way that we can induce and augment labor. Remember that if we're running a critical drip, such as Pitocin or magnesium, that we piggyback it into the mainline IV site. So we piggyback it into the LR. We never put it on its separate IV site alone by itself. It's always piggybacked into the main line and always to the lowest port. And that's because if we have to stop that in an emergency, then we can run in a bolus of our mainline fluid, which is normally LR, and we don't have a whole primary line full of our critical drip that we've been running. Other methods to induce are artificial rupture of membranes. This is done by the physician, and obviously it's a sterile procedure. Cervical ripening agents are also things that we use. So, for example, Cytotec and Cervidil, other prostaglandin agents. We use that to help ripen the cervix and prepare it for labor. Those are ideal to use whenever the Bishop score is not good. And then always when we're inducing someone, we keep them on continuous electronic fetal monitoring. That is a requirement because things such as Pitocin drips and medications like Cytotec are used to create contractions. And we know that those things can cause distress in the baby. So we want to be monitoring that continuously. Okay, so our next high-risk factor when we consider intrapartum issues is preterm labor. And this is the onset of true labor from 20 to 36 weeks. So here you've got to remember the difference between true labor and false labor, right? True labor is what happens whenever contractions are actually dilating and effacing the cervix. So anywhere from 20 to 36 weeks is considered preterm labor. Some major causes of preterm labor are infection, a history, multiple pregnancies, obstetrical procedures such as an amniocentesis or a contraction stress test, and a weak or incompetent cervix. Let's remember that anything that's irritating to the uterus can cause preterm labor because it can cause the uterus to contract. So an amniocentesis, that's irritating to the uterus. We're actually sticking a needle through mom's abdomen and into her uterine wall inside her uterus to the amniotic fluid. That's irritating. Multiple pregnancies, because the uterus becomes so large, quicker than if it had a singleton pregnancy inside. Infections are also irritating to the uterus. So urinary tract infections, chlamydia, gonorrhea, all those things can be causes of preterm labor. Yes, you can go Simon. Some signs and symptoms of preterm labor are abdominal cramping, contractions, a low backache, low abdominal pressure, or mom might have a sensation of pushing down, and then a bleeding or a change in vaginal discharge. So moms may see something like bloody show. The way that we manage preterm labor is through bed rest and hydration. That's usually kind of our first line of management, because what we want to happen is we want these moms to stay super hydrated, because dehydration also will cause contraction. So it's important that they remain hydrated. And also, what do we know about true labor and activity? You've got to remember back a little bit. True labor actually will be made worse through ambulation and activity. So that's why bed rest is important. If mom has an infection, we want to identify that organism that's causing her infection, and we want to treat it. Because if we can get rid of the infection, we can get rid of the irritant to her uterus. And then we want to minimize vaginal examination. If we are constantly checking the mom's cervix to see how far dilated she is, that is irritating as well. So we want to minimize that procedure. We want to assess for signs and symptoms of another type of infection called chorioamnionitis. And that's an infection of the chorion and the amniotic sac of mom. You'll often hear it called chorio. It has really foul smell. And moms will run they'll usually run a temperature with this. The babies tend to become tachycardic when you have a mom with chorio. And if mom has an infection, such as something such as chlamydia, gonorrhea, those types of things, it can turn into choreo. If moms are contracting, or they will be with preterm labor, then we got to administer some medications to stop that if our hydration and bed rest haven't helped. So some different drugs that we can use to arrest contractions are terbutaline, Procardia, or magnesium sulfate. Remember, terbutaline is the shot that we give sub-Q. We can only give it a few times. It is our first-line drug for preterm labor. However, we can't use it for longer than 48 to 72 hours. Procardia is another drug that we can send moms home on. And magnesium sulfate obviously will relax the smooth muscles and help that uterus to not be quite as irritable. If moms are in true preterm labor and we've diagnosed this, then one other type of drug that we give is dexamethasone. This is a corticosteroid, and we give this to benefit the fetus, not the mom, because what this dexamethasone will do is it will actually help the baby's lungs to mature. Because if we know that the baby is going to deliver early or preterm, then we want to give it the best chance possible respiratory-wise. So we're going to try to get those lungs to mature much quicker, which is why we do the steroids. And obviously we have to offer emotional support, because preterm labor and having a preterm infant is not what anybody that's not what anybody expects whenever they get pregnant. And it's a very stressful time. So let's talk quickly about rupture of uterus. Some different causes of rupture of uterus. Probably the main cause that you will find for uterine rupture is an unwise use of Pitocin. We hyperstimulate the uterus. We don't allow it to have enough resting tone as nurses. And so this is something that's completely preventable. And another reason why managing a patient who is on a Pitocin drip is a one-on-one type patient, because this is a critical drug and it can cause some serious problems. People that have had a previous abdominal surgery, specifically a C-section with a classical incision in the uterine wall, those people are at a bigger risk for rupture of uterus, because that scar tissue is not as strong as muscle. And once it's put under the stress of contractions, it can actually cause it to bust open. A baby with a mom that has a large fetus in utero, some polyhydramnios, or other kind of procedures that the doctor may do, such as a version procedure. And that means basically trying to turn the baby one way or another while it's still in utero. And then their forceps-assisted birth is, we've already talked about that one. Let's go back to large fetuses and polyhydramnios. Those couple of things are issues that cause an overextension or an overdistension of the uterus. So again, we're increasing pressure inside the uterus to a point that it just can't hold everything anymore, and it just pops open like a balloon that you blow up too big. Some signs and symptoms of this, if you're taking care of a mom that this happens to, they have a sudden cessation of contractions. There are no more contractions. There's fetal distress immediately. There's a sensation that mom has where she believes something is given way. The fetal parts can be palpable through the abdomen. So that abdomen doesn't have that nice round-looking shape anymore. The fetal parts are actually out in the abdomen, and you can probably actually grab them. Moms will have vomiting. They'll have immediate signs and symptoms of hypovolemic shock, because they will be bleeding out internally. And you may see some vaginal bleeding as well. This is an obstetrical emergency, a big one. We have to administer IV fluids and blood as fast as possible. We have to get them to a stat C-section in a very, very short amount of time, or mom and baby will have a bad outcome. And then we have to control that bleeding, and many times we have to resuscitate that infant because it's been without any type of nourishment if this happens. Amniotic fluid embolism. So you can see here, this is a picture of an amniotic fluid embolism right here. That's the embolism. Some different causes of amniotic fluid embolisms are moms with more than, who've had more than one baby, so a multi-parity mom. Ladies who've had a tumultuous labor. So think back to our dystocia slide. Ladies who've had a tumultuous labor might be those who've had a precipitous labor and some hypertonic contractions, and the labor happened really fast. It was rough. That's a possibility to cause amniotic fluid embolism. Moms with an abruption. There you see oxytocin administration again. Those large babies that are macrosomic. Hydramnios is another cause. Moms with fetal demise. And meconium-stained amniotic fluid. All of those are causes of amniotic fluid embolism. The signs and symptoms that you're going to see if this happens to a mother you're taking care of, they're going to end up with some sharp chest pain, some dyspnea, cyanosis. Eventually, they will end up in cardiac arrest, and the mortality rate for amniotic fluid embolism is very high. It's very difficult to manage this situation, so we want to do everything we can to prevent it and not have to manage it. These moms will become hypotensive. They'll be very anxious. They have this impending sense of doom. Restless. Their respirations will become labored. And another thing to note here is that this can happen after the placenta delivers. So as the nurse, you always want to be assessing your patient after that placenta delivers, because this is a complication that can occur after placental delivery, and we want to be prepared to manage it. This is an obstetrical emergency, and if it happens, we want to throw on some oxygen at 8 to 10 liters via a mask. We want to start running in some IV fluids as quickly as possible. We want to begin CPR, start some proper positioning depending on if the baby's being delivered or not, administer blood. Mom may need a Foley so we can monitor eyes and nose. We obviously want to monitor the fetal heart rate and maternal vital signs, prepare mom for a C-section if she is still pregnant, and assist with intubation, because these moms are not going to be able to breathe. Whoa. These moms will not be able to breathe, and we're going to have to mechanically ventilate them, and sometimes that still does not even work. Umbilical cord prolapse is another high-risk factor that we can experience intrapartum, and some causes for umbilical cord prolapse happen to be premature rupture of membrane prior to engagement. So that means the fetal head is not engaged, membranes have ruptured, and it's allowed a space there between the fetal head and the pelvic inlet for the umbilical cord to slip through. Babies who are at a transverse lie also have a greater risk for having that umbilical cord prolapse, because obviously they can't get engaged into the pelvis. Babies who are small for gestational age allow more room in the pelvic structure because their heads are smaller or their bodies are smaller. Babies that have an unusually long cord are at a greater risk. Moms that have multi-fetal pregnancies are at greater risk. Obviously, if you got a multi-fetal pregnancy, we got 2 umbilical cords. So there's just a greater chance for one of them to slip through there. Cephalopelvic disproportion is another cause. Ladies with placenta previas. You can imagine if we have a mom who's got a marginal placenta previa or a partial placenta previa, the risk for that umbilical cord to slip through into the pelvis and out into the vagina is much greater than if her placenta is located appropriately up towards the top of the uterus. Moms with polyhydramnios or oligohydramnios, remember that amniotic fluid in the right amount is very good for the baby and the cord. When we have too much or too little, then umbilical cord prolapse can be an issue. What happens to the baby and mom if the umbilical cord does prolapse through is that there is pressure placed on the cord by by the fetal presenting part. So if the head is down, for example, in this picture here, if the head is down and the cord slips through, obviously the baby's head is going to be compressing the cord. That's going to obstruct the transport of oxygen to the baby, and it's going to cause fetal hypoxia, and there's going to be a terrible outcome. Usually, moms will say that they feel something down there. You may be able to actually visualize the cord in between her legs, or you may be able to palpate the cord. So if you can't see it and you go to do a sterile vaginal exam, then what you would feel is actually a pulsating structure. If you do a sterile vaginal exam and you feel a pulse, that is not normal. That would be a firm indication that you probably have a prolapsed cord that just isn't visible. On the fetal heart rate strip, some things you might find are variable and prolonged deceleration. There will be an extreme increase in fetal activity and then a cessation of that activity. And that can come and go because you think about it in terms of somebody cutting off your airway supply. You're going to have a lot of activity to start with until you pass out, right? Kind of the same concept, for lack of a better way to explain that. This is an OB emergency. We have to check the fetal heart rate after the rupture of membranes to make sure that we don't end up with a cord prolapse. We also have to keep these moms on bed rest, especially if they have ruptured membranes and the fetal presenting part is not engaged. We would not allow those moms to get up and ambulate around the hallway. If you find one of these, the way we manage it is that we relieve pressure off of the cord with a gloved finger. If you do a sterile vaginal exam and you find that there is a cord prolapse, you don't get to take your hand out. You have to leave it there and put upward pressure on the fetal presenting part to keep it off of the cord. We got to administer oxygen to mom so we can oxygenate baby. We prepare her for a C-section. We'll put her in Trendelenburg or knee-chest position, and really knee-chest position tends to work better. If you can flip her in knee-chest, that's the best way. And then we want to hold the head or the presenting part off of the cord if that's possible. Sorry, guys, I'm trying to manage the baby and finish this lecture up. He just woke up. Okay. I want you to think about one thing here, though. In terms of an umbilical cord prolapse, we've said that this is an OB emergency, and always whenever you think of emergencies, you want to know what's your priority nursing action. What's going to fix that the fastest? So in terms of your nursing measures, the quickest way that you can get pressure off of that cord is with a position change for mom. If you've discovered this, if you've visualized it, the first thing you want to do is ask that mom to roll over in knee-chest position, because that's the fastest way that you're going to get pressure off of that umbilical cord. Another high-risk factor are moms that have meconium-stained amniotic fluid. Now, meconium is that first stool that babies pass after they're born, and babies that pass this stool in utero it happens because of a loss of their sphincter control, and usually that has to do with some type of hypoxic insult that they have experienced inside mom. So it could be something like cord compression. It's at a much greater risk after 38 weeks, and that should make sense because babies are getting bigger by that point. There's much more chance of them to compress the cord somewhere because they're bigger. Also, remember, the placenta starts to age out at a certain point in mom's gestation. So those moms who are post-term, those babies have more of a chance of ending up with a hypoxic insult because the placenta just doesn't perfuse like it normally would. Signs and symptoms you might see as the nurse are black, green, yellow, or brown colored amniotic fluid. You know, amniotic fluid should be clear. If you see that it has any of these other colors in it, then you've got some meconium. Meconium can be characterized as thick or thin, and you assess this visually after membranes have ruptured. Distress can be verified, fetal distress that is, can be verified when you have meconium and you interpret variable and late decelerations on the fetal heart rate tracing. If you see both of those things, meconium when the fluid ruptures and variable and late decelerations on your fetal heart rate strip, you can rest assured that your baby is in distress. We manage this through, obviously we always document. We want to document the COCA of that amniotic fluid. We can start an amnio infusion. So this is where we run fluid into mom's uterus, and usually that's normal saline. We'll bolus that into her uterine cavity through an IUPC. And if we do this, then one thing we have to do is we've got to keep track of what's going in and what's coming out. Because if we don't, we're putting this mom at a great risk for uterine rupture if we infuse a lot of fluid and it doesn't come back out. Obviously, we are going to monitor the fetal heart rate. We're going to treat any late or variable decelerations that we might interpret on the fetal heart rate monitor strip with some intrauterine resuscitation measures. That could include that amnio infusion. That could include a fluid bolus, some oxygen, position changes, all of those things on that slide we discussed previously.
Can you please be quiet so I can finish talking? Thank you.
We are going to prepare to deliver a low APGAR score infant. And we want to notify the nursery nurse and the respiratory therapy of this. If we have verified we have some fetal distress through meconium and later or variable decels, then you can expect that you're going to have some respiratory issues and possibly a low APGAR at birth. We do not want to stimulate the baby to breathe whenever it's born. And the reason is because once that baby takes that first breath, it's going to suck all that meconium down into its lungs, and now we've got another issue, which is risk for meconium aspiration. We do not want to use a bag and mask to deliver oxygen to a baby if they're in respiratory distress and they've been delivered in meconium-stained amniotic fluid. Because if we bag and mask some oxygen into the baby's lungs, then what we've done is we've pushed that meconium even deeper into their airway. If they're born vaginally, we don't want to suction them on the perineum. That means when the doctor uses that bulb syringe to suck out the mouth and the nose prior to delivery of body, I don't want to do that, but that will actually stimulate them to breathe. We use a laryngoscope to suction out the lungs instead. So that's a piece of equipment that your nursery nurse and your respiratory therapist would want to have ready. Because once this baby is born, if it's not breathing, then what they're going to want to do is visualize the airway with a laryngoscope, insert a suction catheter, and do some oropharyngeal suctioning to get out as much of that meconium as possible. Some complications that babies may experience related to meconium-stained amniotic fluid are asphyxia, aspiration, and pneumonia. This can be a pretty ugly meconium aspiration syndrome. Can be a pretty ugly disease for babies, and they can actually die from it. So it's very serious. Now, with all of that said, some of the new research coming out and some of the new evidence-based practice is actually showing that it does not make much difference if we don't stimulate them to breathe or if we, don't suction on the perineum. Some of our new evidence-based practice actually is saying that it really doesn't matter because they already have that meconium in their lungs anyway from in utero. So just kind of something for you to keep in the back of your mind there. Couple of more slides. Another high-risk factor in the fetus is umbilical cord abnormalities. So a two-vessel cord, you can see that in this picture up on the right-hand side. We've got one artery and one vein, and that means that baby doesn't get quite as much nutrients. Unusual cord length, short or long. That can also be a high-risk factor. If the cord is too short and we're doing a vaginal delivery, then it's a possibility that it could shear and actually snap during vaginal delivery. If it's too long, then obviously we might have the possibility for umbilical cord prolapse. I'm so glad that you're telling everybody, hey, but I only have 2 more slides. Can you please be quiet? A velamentous insertion of the cord and vasa previa. That's these 2 things right here, those 2 pictures. And you don't have to know those exactly. I just wanted to show you what those were so that you would have an idea of what they are if you heard of them out in clinical or anywhere. But you can see how the umbilical cord has sort of grown into the amniotic sac in these pictures, and that can also cause issues. And then we have placental abnormalities. You do not have to know each of these individually or in depth. I just want you to know that there are these different types of placental abnormalities, and what happens in these is that the placenta embeds itself too deep into the uterine wall, and this causes a huge issue when it comes time for that 3rd stage of labor whenever mom gets ready to deliver the placenta, because if it's embedded too deep in the uterine wall, it's not going to come out. Many times these women end up having to have a hysterectomy, and they are at a big, huge risk for postpartum hemorrhage. So, that is the end of individual module 5.2. This is PowerPoint 2 and the end of lecture 4. Thanks for listening, and we'll continue on with 5.3 whenever I'm not holding the baby on my hip. Have a good day.